Deep vein thrombosis kills silently, and what worries me most after years as a cardiologist is not the complexity of the condition itself, but the devastating simplicity of what often triggers it. A clot that forms during sleep, in a vein that was being compressed by the wrong position for hours on end, in a body over 60 that already has slower circulation, less elastic veins, and blood more prone to clotting than it did 2 decades earlier, and the person wakes up in the morning without knowing that something dangerous was forming while they slept, or they don't wake up. You probably never connected the position in which you sleep to the risk of thrombosis. Most people don't. They think of thrombosis as something that happens on long flights, in surgeries, in bedridden people, not as something that can be favored by the position you repeat every night for 7 or 8 hours in your own bedroom. But that is exactly what the clinical evidence shows, and that is exactly why I am making this video. Because the information I am going to share today does not appear in routine 15-minute consultations, it does not appear in medication inserts for blood pressure, and it does not appear in any of the conversations about cardiovascular health that most Americans over 60 have ever had with a doctor. It is an information gap that has real consequences. And today I am going to close it for you with the clarity and specificity the subject deserves. I will explain what deep vein thrombosis is, how it forms during sleep, which positions create the perfect conditions for a clot to develop, which position the evidence indicates is protective, and the practical protocol to implement this change tonight. Click subscribe now and hit the bell, and let's start with what is actually happening inside your veins while you sleep. Deep vein thrombosis, DVT in the American medical system, is the formation of a blood clot within a deep vein, usually in the legs, but it can develop in any region where blood flow is sufficiently compromised for enough time for clotting conditions to be established. And here is what most people have never heard with the clarity it deserves. The clot does not form instantly. It is not an acute event like a heart attack where an artery suddenly closes. It is a process that develops progressively over hours of inadequate blood flow, of blood that is moving too slowly through a vein that is being partially compressed, and of clotting factors that in people over 60 are already naturally more active than in younger adults. Virchow's Triad, the model that medicine has used for more than 150 years to understand clot formation, identifies three conditions that, when present simultaneously, create the ideal environment for thrombosis. The first is venous stasis, blood that is not moving properly. The second is endothelial injury, damage to the inner lining of the vein. And the third is hypercoagulability, blood that is more prone to clotting than it should be. After age 60, all three conditions are present in varying degrees in most American adults. Circulation is naturally slower. Venous walls have lost some of the elasticity that kept them smooth and functional, and clotting factors tend to be more active. Sleep adds the temporal dimension that completes the scenario. 7 to 8 hours of relative immobility during which blood moves with even greater slowness than during the day, and during which the position of the body directly determines which veins are receiving adequate flow and which are being compressed in ways that favor stasis. What happens specifically inside a vein during hours of compression or improper positioning is a biochemical process that most people have never visualized with the concreteness that makes the risk real and immediate rather than abstract and distant. When a deep vein is partially compressed, whether by the weight of the body positioned in a way that concentrates pressure on certain regions, or by excessive flexion of a joint that narrows the underlying venous lumen, the blood in that segment begins to move more slowly. Red blood cells, platelets, and clotting factors that normally flow separately and in motion begin to concentrate. Platelets, which are the first cells to respond to any change in blood flow, begin to aggregate. Clotting factors begin to activate the cascade that eventually produces fibrin, the protein that forms the structure of the clot. And what started as a slight reduction in blood flow in a vein in the legs during the first 2 hours of sleep can, over 6 or 7 hours of immobility in the same position, have progressed into a thrombus that partially occupies the venous lumen. The person wakes up, stands up, and the clot that was relatively stable in the horizontal position is suddenly subject to the hemodynamic forces of the vertical position and movement. And it is at this moment that the risk of pulmonary embolism becomes real and immediate. A fragment of the thrombus breaks off, travels through the venous circulation, passes through the right heart, and lodges in the pulmonary circulation. The result can range from respiratory difficulty to sudden death, depending on the size of the fragment and the person's cardiorespiratory reserve. And it all started with the position in which they slept for the last few hours. The reason why the risk of thrombosis during sleep increases specifically after age 60, and it is not just a matter of having more accumulated lifetime, is in specific physiological changes that occur progressively in this stage and that no routine exam measures directly. Blood viscosity increases slightly with aging. The blood gets a little thicker, a little more prone to clotting under conditions of reduced flow. The function of the venous valves in the legs, which are the structures that prevent blood backflow and maintain one-way flow toward the heart, deteriorates progressively after age 50, creating regions of turbulent and slow flow that are favorable environments for platelet aggregation. The elasticity of the venous walls decreases, reducing the ability of the veins to actively contract to propel blood toward the heart during rest. And fibrinolytic activity, the body's ability to spontaneously dissolve small clots before they become clinically relevant, also decreases with aging, which means that small thrombi that in younger adults would be dissolved before causing any problem can persist and grow in adults over 60. Each of these factors individually represents a modest risk. Combined with 7 hours of immobility in the wrong position, repeated 365 times a year, year after year, they represent a risk that is completely real, completely documented, and completely avoidable with the right information applied consistently. There is a sleep position that consistently appears in the history of patients who arrive at the emergency room with deep vein thrombosis without any obvious risk factor like recent surgery, long travel, or prolonged immobilization. And that position is what sleep medicine specialists call the advanced asymmetrical fetal position, which is essentially lying on your side with knees flexed at a sharp angle and crossed so that the weight of one leg directly compresses the veins of the other. Most people who sleep this way do not know they are doing it. They fall asleep on their side, move during sleep, and wake up in this configuration with no memory of the transition. What happens hemodynamically in this position during hours of sleep is specific and documented. The popliteal vein, which is the main deep vein of the posterior region of the knee and which is one of the most common locations for the onset of deep vein thrombosis, is compressed by the weight and pressure of the upper leg on the lower one. Blood flow in this segment drops dramatically. Virchow's conditions that we discussed in the previous topic are established with clinical precision: stasis, endothelium under pressure, and basal hypercoagulability of the adult over 60. Hours later, when the person wakes up and moves, the thrombus that formed is subject to forces that can fragment it. The characteristic pain and swelling of thrombosis appear, frequently attributed to a nighttime cramp, a physical effort, a bad position, while the clot continues to grow without diagnosis and without treatment. The belly down position, prone position, is the one that presents the most comprehensive risk profile for thrombosis and for general cardiovascular health in adults over 60, and it is also the most difficult position to give up when it is established as a habit of decades. The central hemodynamic problem of the prone position is the direct compression of abdominal and pelvic veins by the weight of the body itself against the mattress. The inferior vena cava, which is the largest vein in the body, responsible for returning all venous blood from the lower half of the body to the heart, is compressed by the weight of the abdominal structures resting on it when the person is lying on their stomach. This compression reduces venous return from the entire lower territory of the body, creating a condition of stasis that affects not only the legs, but the entire abdominal and pelvic venous circulation. For an adult over 60 who already has compromised venous circulation, who may be taking medications that affect clotting, and who will remain in this position for 7 or 8 hours, this compression of the inferior vena cava during the entire sleep period is a risk factor for thrombosis that most people never imagined they were creating every night in their own bed. There is also the cervical component that worsens the situation. Lying on your stomach, the head must be rotated laterally to allow breathing, which compresses the jugular and vertebral veins on the side to which the head is turned, reducing venous return from the head and neck, and potentially contributing to morning headaches that many people attribute to the pillow without knowing that the cause is hemodynamic. The belly up position, supine position, has a risk profile for thrombosis that is more nuanced and that depends significantly on how the legs are positioned during sleep. When the person sleeps completely flat on their back without any leg elevation and with the knees extended, venous return from the legs depends exclusively on residual venous pressure and muscle contractions, which during deep sleep are at a minimum. The blood in the veins of the legs moves with a slowness that in adults over 60 with some degree of venous insufficiency can be enough to create the conditions of stasis that favor thrombosis in the deepest hours of the early morning. There is also the problem of sleep apnea, which is significantly more common in the supine position for anatomical reasons related to the fall of the tongue and soft tissues of the throat by the action of gravity, and which creates its own cardiovascular risks through mechanisms that include blood pressure spikes during apnea episodes, activation of the sympathetic nervous system, and increased inflammatory markers that compromise the vascular endothelium. The combination of venous stasis in the legs, blood pressure spikes during apnea episodes, and an elevated inflammatory state creates a convergence of risk factors for thrombosis that happens every night in the sleep of American adults over 60 who sleep on their backs without any intervention, and that could be significantly reduced with simple and immediate changes in sleep position and environment. After everything we discussed about the positions that create conditions favorable to the formation of clots, the time has come to present the other side of this equation, the position that clinical evidence and vascular physiology identify as the most protective for adults over 60 regarding the risk of deep vein thrombosis. And the answer is the left lateral decubitus, sleeping on the left side, with legs slightly flexed and separated by a pillow between the knees. The reason why the left side specifically receives special attention in cardiovascular medicine is in the anatomy of the inferior vena cava. This vein, which returns all venous blood from the lower half of the body to the heart, runs slightly to the right of the body's midline. When you sleep on your left side, the inferior vena cava is not being compressed by the weight of the abdominal structures. It is positioned so that venous return happens with less resistance and greater efficiency than in any other sleep position. This means that blood from the legs, feet, and the entire abdominal and pelvic venous circulation is moving more easily toward the heart during the hours of sleep, creating hemodynamic conditions that are the opposite of the conditions that favor thrombosis. Moving blood does not clot with the same ease as stagnant blood, and the left lateral position maximizes passive venous movement during sleep in ways that no other position can replicate with the same anatomical efficiency. For adults over 60 who already have naturally reduced venous circulation speed, this anatomical advantage of the left lateral decubitus is not trivial. It is a real hemodynamic difference that accumulates over 7 or 8 hours of sleep, and that, repeated 365 times a year, represents significant protection against the development of venous thrombosis in the most vulnerable hours of the daily cardiovascular cycle. The pillow between the knees, which seems like a minor detail but is just as important as the lateral position itself, solves the specific problem we discussed regarding the advanced asymmetrical fetal position where one leg compresses the veins of the other. When there is a pillow between the knees in the lateral position, the upper leg is supported in a position that keeps the hips parallel and prevents the weight of the upper thigh and leg from descending onto the lower leg. The popliteal vein, the one that is one of the most common locations for the onset of deep vein thrombosis, remains uncompressed throughout the night. Blood flow in this critical segment remains adequate, and the pelvis remains in a neutral position that does not create twists or compressions in the pelvic vascular structures that the lateral decubitus without support often produces when the upper hip falls into internal rotation by the action of gravity over hours of sleep. There is an additional dimension of the left lateral decubitus that goes beyond venous hemodynamics and that is relevant for anyone over 60 concerned with general cardiovascular health. The effect on the autonomic nervous system during sleep. Research on sleep position and the activity of the vagus nerve, the main nerve of the parasympathetic system that regulates heart rate, blood pressure, and systemic inflammation, suggests that the left lateral decubitus favors a more efficient activation of the parasympathetic system during sleep, producing a state of deeper cardiovascular rest that translates into lower nocturnal heart rate, lower blood pressure during sleep, and a lower level of inflammatory markers that compromise the vascular endothelium. Healthy endothelium is endothelium less prone to being the starting point of thrombosis, which closes the cycle of protection that the left lateral decubitus offers to the vascular system of adults over 60. There is an important caveat that needs to be communicated with the same clarity as everything I have said so far, and to omit it would be a clinical dishonesty that I cannot allow. For people with diagnosed heart failure, especially those with left ventricular dysfunction, the left lateral decubitus can cause discomfort or palpitations because the enlarged heart that often accompanies this condition is in more direct contact with the chest wall in this position. If you have heart failure and your cardiologist has recommended a specific sleep position different from what I am describing, follow your doctor's guidance who knows your specific case, because the recommendations I am presenting are directed at the general population of adults over 60 without a specific diagnosis of heart failure. For everyone else, and this includes the vast majority of American adults over 60, the left lateral decubitus with a pillow between the knees is the position that vascular physiology indicates as most protective against positional deep vein thrombosis, and it is the position that I recommend as part of any preventive cardiovascular health strategy after age 60. This recommendation does not replace individualized medical evaluation, but it provides the information and language for you to go to your doctor and say, I heard about the left lateral decubitus for thrombosis prevention. Is this appropriate for me given my history? This question, asked with real knowledge, is an act of advocacy for your own health that can completely change the conversation you have in the next consultations. Changing sleep position after decades of sleeping the same way does not happen in one night, and any approach that ignores this reality will produce 2 or 3 days of frustrated attempts, followed by abandonment and return to the original position. The protocol I am going to present to you was developed over years of working with patients who needed to make this transition for specific clinical reasons. And it works because it respects the physiology of sleep instead of trying to force it. The first element is the long body pillow, a full body pillow positioned along your front when you lie on your side. This pillow serves 3 simultaneous functions that are all equally important for the success of the transition. First, it gives the upper arm and leg a place to rest that keeps the body in the lateral position without the active muscular effort that would be necessary to maintain the position without support. And without this effort, the body does not have the discomfort that normally makes it roll to the more familiar position during deep sleep. Second, it prevents you from rolling forward and falling into the prone position, the position of highest risk during sleep. Third, it creates a feeling of support and security that the nervous system associates with comfort, making it easier to fall asleep in the new position instead of the body being in a state of alert, trying to readjust to what is familiar. The pillow between the knees, separate from the body pillow, is the second element, and we already discussed its importance for keeping the popliteal vein uncompressed throughout the night. A medium-sized memory foam pillow is sufficient. The goal is not significant elevation, but simply keeping the knees apart and the hips parallel during sleep. The third element of the protocol, and the one that most consistently makes the difference between people who manage to make the transition and people who do not, is the dorsal barrier method. This method consists of positioning a firm roll or a rolled and tied pillow behind your back so that when you try to roll into the supine position during sleep, the physical barrier causes a slight discomfort that makes you unconsciously return to the lateral position without waking up completely. It is a passive postural conditioning that operates during deep sleep, exactly when conscious control over position is not available. Some sleep medicine specialists recommend the version with a tennis ball sewn to the pajamas on the back. The principle is the same. The discomfort of the ball when you roll over it is enough to produce the postural correction without interrupting sleep. Most patients who implement this method consistently for 2 to 3 weeks report that after this period, the body has already internalized the lateral position as the natural sleep position, and the barrier is no longer necessary. The fourth element is the main pillow of adequate height, which is a detail that seems minor but has a direct impact on both the comfort and sustainability of the lateral position. In the side position, the distance between the shoulder and the head is significantly greater than in the back position, which means that a low pillow that was adequate in the supine position will let the head fall to the mattress in the lateral position, creating cervical tension that produces enough discomfort to make the body seek a more comfortable position during sleep. A firm, higher pillow, specifically sized for shoulder width, keeps the neck in a neutral position and lateral sleep comfortable all night long. The warning signs of deep vein thrombosis that need to be recognized immediately, because early diagnosis is the most important factor in preventing serious complications, including pulmonary embolism, are specific and frequently confused with more benign conditions that dangerously delay diagnosis. The first and most common is calf pain, usually described as a throbbing or cramping pain that worsens when you stand or walk and can resemble an intense muscle cramp. The critical difference is that common muscle cramps improve quickly with movement and stretching, while pain from thrombosis persists and often worsens with movement. The second sign is localized swelling in one of the legs, frequently just one, not both, that appears for no obvious reason such as trauma, intense physical effort, or insect bite. Swelling from thrombosis tends to be accompanied by heat and redness in the affected region that reflect the inflammatory response to the clot inside the vein. The third sign, and the most urgent of all, the one that requires an immediate emergency call, is sudden chest pain combined with shortness of breath that appears suddenly without physical effort to explain it. These are the classic symptoms of pulmonary embolism, the thrombus fragment that broke off from the leg vein and lodged in the pulmonary circulation, and represent a life-threatening medical emergency that requires immediate hospital evaluation. If you wake up in the morning with any combination of these symptoms after a night of sleep in the wrong position, do not wait to see if it improves. Do not attribute it to a cramp or yesterday's effort. Call 911 or have someone take you to the emergency room immediately. The time between the onset of symptoms and treatment is the most determining factor of the outcome in pulmonary embolism, and every hour of waiting can be the difference between complete recovery and permanent complications. I want you to take one thing above all others from this video, and I say this with the seriousness of someone who has spent years sitting in front of patients whose lives were permanently altered by a condition that could have been prevented with information that simply never reached them at the right time. Deep vein thrombosis is not a rare, exotic, or unpredictable condition. It is a condition with well-understood biological mechanisms, with identifiable risk factors, and with specific preventive interventions that anyone can implement without cost, without medication, and without any dramatic change in routine other than how they position their body during sleep hours. You learned today how a clot forms progressively over hours of inadequate blood flow, how Virchow's Triad operates silently in the veins of adults over 60 whose blood is more viscous, whose venous walls have lost elasticity, and whose fibrinolytic capacity is reduced. You understood which positions create the perfect conditions for this process: the prone position that compresses the inferior vena cava, the advanced asymmetrical fetal position that compresses the popliteal vein, the supine position without support that combines venous stasis with the pressure spikes of sleep apnea. You learned about the position that vascular physiology indicates as protective, the left lateral decubitus with a pillow between the knees, and the practical four-element protocol to make this transition sustainably even after decades of sleeping the same way. And you now have the warning signs that can never again be ignored or attributed to benign causes without proper medical evaluation: persistent calf pain, unilateral swelling with heat and redness, and the combination of sudden chest pain with shortness of breath that requires immediate emergency call. This information changes what you're going to do tonight when you turn out the light. And what you do tonight will accumulate over weeks, months, and years in a vascular protection that no routine exam measures, but that the body records with a fidelity that eventually appears in the results that matter. The last thing I need to say, and I say this as a doctor who believes that information is the most powerful preventive instrument available to anyone willing to use it, is that this video does not replace an individualized medical evaluation. If you have a history of thrombosis, if you are taking anticoagulants, if you have diagnosed heart failure or any other cardiovascular condition that your doctor actively monitors, take what you learned today to the next consultation and ask directly how this applies to your specific case. The conversation you will be able to have with your doctor after watching this video is a different conversation than the one you would have without this information, because you will arrive with specific questions, with clear concepts, and with the awareness that sleep position is a modifiable cardiovascular risk factor that deserves to be on the agenda of any preventive health consultation for adults over 60. This advocacy for your own health, based on real information and not on anxiety, is what separates patients who identify problems in an early stage from those who arrive at the emergency room with situations that should have been prevented. You have this information now. Use it. Now, I genuinely want to hear from you. 3 questions to answer in the comments right now. First, in which position did you sleep before watching this video? And after everything you learned today, are you going to change tonight? Write it here because the answer will tell me how much this information is still not reaching the people who need it most before a clot forms. Second, have you or someone you love already had an episode of deep vein thrombosis or pulmonary embolism and only discovered the cause after the damage was already done? Write it here because each experience shared in the comments can be what convinces another person watching to take the warning signs seriously instead of waiting to see. And third, where are you watching from? City, state, country, and how old are you? If this video was valuable for you, if it finally connected something you did every night with a risk that was being created while you slept, convinced you were resting, share it now with someone you love. A family member over 60 who has been sleeping on their stomach for decades without knowing what they are doing to their own veins. A friend who wakes up with calf pain frequently and never connected it to sleep position. Someone you want to still be present 10 years from now with enough health to enjoy every moment. Press the like button. This helps this channel reach more Americans who need this information. Click subscribe now and hit the bell so you don't miss any content like this. Take care of your veins. They work for you every night without asking for anything in return, and the protection they need begins tonight, with a pillow between the knees and the left side of your body facing the mattress.